All right. Well, welcome everyone to the first session of this series on creating and maintaining a culture of safety. My name is Brian Sexton. I'll be your moderator for today. I'm a psychologist and a psychometrician, meaning that I create and validate metrics in particular for safety culture and for workforce well-being. So it's with great interest that we introduce this essential topic today of psychological safety. But before we get started, if we can go to the next slide, we will be recording the session today. It will be available and posted on the National Action Alliance website. Please, throughout the webinar today, use the chat function to engage with us throughout the webinar and throughout the Q&A. And also closed captioning will be available in the lower left-hand corner of your screen. We also want to give a shout out. We encourage all interested healthcare systems to visit the National Action Alliance's website to understand the commitment process to the Alliance, which involves having an executive leader in safety pledge on behalf of the organization. Organizations can formalize their commitment by submitting it via email to the link that you can find in the chat right now. Next slide. As we get going today, I want to let you know this is the first of a three-part series that is scheduled right now for February, March, and April of this year. We'll be doing psychological safety today. Next month is planned teamwork and patient safety norms, things that you can do to improve teamwork and things that you can do to improve patient safety norms. And then in April, we have scheduled on safety culture, how to measure it and what to do about it more broadly. It might sound boring, but that third one's going to be really interesting and fun too. I bet you'll hear some things that you haven't heard before about that particular topic. Go ahead, next slide. So today, when we're talking about culture, just to set the stage a little bit, when we're talking about culture, we're talking about the way we do things around here. And your safety culture isn't like your words on your website or your posters on a wall. It's how your people feel on a Sunday night before they have to go back to work on a Monday morning. And your culture is local. So your work culture impacts your behavior, and your behavior impacts that work culture locally. And as you've probably heard before, culture eats strategy for lunch. You can have the best of ideas, but if your culture kind of supersedes it, those ideas go into the waste bin of history. Go to the next slide. I want to talk a little bit about how we've learned and how we came to be thinking even more about psychological safety. So I want to talk about leader rounding for a moment. So leader rounding has been associated with outcomes on the HSOPS Safety Culture Survey and the SAQ Safety Culture Survey, and as well as the SCORE Safety Culture Survey. HSOPS, as you can see here, is responsive. So scores on your safety culture survey are responsive to leader rounding activities. Now, this began, we actually did this work with our colleague Jochen Profit at Stanford. He's a neonatologist, and we had a large cohort of neonatal ICUs that we could kind of have the same kind of work setting and look at these rounding behaviors across the work settings. And what we found actually was that when there's more leader rounding, and it wasn't just by asking people on their safety culture survey, did you attend one of these leader rounding sessions, but rather we asked them, did you get feedback about these leader roundings? And what we found is that the idea of getting feedback actually suggested that that rounding was happening regularly, actions were being taken, there was feedback about actions being taken, and it just suggested a more robust program. We did see a signal if you just say, I was present for one of these leadership visits to my unit, yes, no, not sure. We did see a signal, but the signal was much, much stronger if you asked about feedback. And in doing so, if you look here on the screen in the figure where it says SAQ and AHRQ HSOPs, you'll see something kind of interesting. Not only did we detect differences in things like teamwork and patient safety norms, in particular on the HSOP survey, overall perceptions of safety was pretty responsive to kind of leader rounding behaviors, but also we found this trend for burnout. So in those work settings where there was more of this leader rounding, there was less burnout reported in those work settings. And that really got us thinking about why that would be, and would it be possible, for example, to tweak the whole concept of rounding so that you're tackling this issue of feeling safe at work and feeling whole at work more directly. And that's starting to kind of push us more into the psychological safety realm. If we can go to the next slide, we then put into a horse race. If we can go to, a horse race, the concept of traditional patient safety leader rounding, that's what's on the left side there, and then positive leader rounding, where we were also asking about the staff, like, how is it going? What are you looking forward to? What's something that's going well? Kind of despite the universe kind of throwing all kinds of interesting things at us this week, what's going well in the work setting right now? Oh, and then what are some things that we could be doing to make things safer for our patients? And so we didn't just ask about the deficits, we also asked about what was going well. And that created a situation where the leader in those brief interactions was able to generate psychological safety with the staff. The staff felt more voiced. They felt like they had more of an opportunity to talk about things that were going well and things that weren't necessarily going well. And what was interesting here, and the term psychological safety, just very briefly, comes to us from Dr. Amy Edmondson at Harvard, who kind of coined the phrase in her research in the late 1990s. But it's basically, do you feel comfortable speaking up with concerns, or maybe talking about something that you've done wrong, that you have a fear that maybe you did something wrong? Can you talk about that openly? And it really emerged out of safety culture items about teamwork norms and patient safety norms. So teamwork norms would be, I can resolve conflicts, I can ask questions. If there's something I don't understand, I can speak up. If there's something that I feel a concern about, that's a teamworky norm. But on the patient safety norm side, we actually have things like errors are handled appropriately, and we can learn from the mistakes of others. And my suggestions about quality would be acted upon if I express them to management. Those are teamworky norms and patient safety norms that, when you put them together, they form the foundation of just, do I have a voice? Can we talk about our teamwork? Can we talk about our coordination? Can we talk about our patient safety and even mistakes that happen at work? So voice. And what we thought was really interesting is, if you look at the horse race on the left-hand side, patient safety rounding, and on the right-hand side, positive rounding, which was designed to be more psychologically safe, kind of pull people kind of into the conversation more directly. We can measure psychological safety in both scenarios. And on the left-hand side, you can see, when you do leader rounding and you're just talking about risks and patient safety, yes, we do see an improvement. When there's more of that rounding, there's more psychological safety. But on the right-hand side, that effect is twice the size. It's even bigger effect when you pull people out of their shells and make them feel comfortable. You'll hear some examples of that from our speakers today. But I just wanted to point out, number one, you can measure psychological safety. Number two, it kind of emerged out as one of the most important domains within a culture of safety. And that we don't just ask people, were you present? Yes, no. We ask, have you received feedback about actions taken as a result of these rounds? And that kind of implied a more robust rounding, a more frequent rounding, a more kind of meaningful rounding structure that led to those perceptions being even stronger. So with this kind of introduction in mind, what is psychological safety? Just think of it as voice. Can people say what they're thinking comfortably? If we can go to the next slide, the questions that we want to run on today are, what are some specific strategies that can be used to create and maintain psychological safety? You're going to hear about that from both of our speakers. And also, what outcomes can be impacted by improving psychological safety? You've already heard a little bit about that here today, but keep that in mind as we go into and start to listen to our guest speakers. The first of whom I'd love to introduce, her name is Dr. Tracy Goslin. She's the Senior Vice President and Chief Nurse Executive and Chair of Nursing at Memorial Sloan Kettering Cancer Center. Before assuming this role, she served in many senior leadership roles at Duke Health, where she started as a staff nurse in 1993. I could read her many publications and awards and memberships, but as someone who knows the impact that Tracy has on countless work settings, I can tell you she is an excellent example of how leaders can adjust their leadership style to create and enhance psychological safety during times of tumult and times of uncertainty. Please welcome to the session today, Dr. Tracy Goslin.
Thank you, Brian, and thank you for the invitation to be here to speak to everyone. I'm really excited about this topic and think it is a topic that we can all learn from, right? When we think about the work, the roles we hold, right, and the people we support. I think one of the key pieces when I think about leadership rounds, it's really about how do leaders connect with frontline staff and team members of different disciplines, right? In 1999, the Institute for Healthcare Improvement conceptualized walk rounds, right? with senior leaders walking, engaging the front line, getting feedback, asking questions, that in-person type of event, which we know has changed over recent years as we think about the work we do and how we do it. And not just in healthcare, in a variety of work streams. We also have to recognize that the front line is the experts, right? And I think we can also learn from the work of Hewlett Packard and Toyota when we think about work streams, improving quality, improving safety, and ultimately improving outcomes. So when you think about leadership rounds, I'm going to give you two examples from the literature. One is very specifically focused on hospital-acquired infections. And you might be thinking, well, why is that important? Well, based on recent literature, what we know is 1 in 31 patients will have a hospital-acquired infection. And why does this matter? Well, this matters for the institution, right? When we think about reimbursement, when we think about CMS and payers, we also know it matters to the person who experiences a hospital-acquired infection. We talk about it in percentages and numbers, right? But often we don't see the person, right? But that person is usually somebody else's person, and that's why it matters. We also know when we think about this space of hospital-acquired infections, there's been a lot of evidence-based practice guidelines, toolkits in managing care, really trying to look at how do we improve care. So this is just one study. There's many others out there around hospital-acquired infections and using leadership rounds, and they focused very specifically on catheter-acquired urinary tract infections, right? Large academic medical center in the Midwest, 19 inpatient units with unit-level observations, and they collected these observations 22 times over 7 months. They did some semi-structured interviews from key informants, learning from them, understanding what they wanted to learn, and then moved into data analysis, right? Looking at the structure of the rounds, meaning how were they held? How were they facilitated? How were they scheduled? A variety of different things that support the elements of leadership rounds. I think the also important piece is when we talk about some of the frameworks they used for content analysis, right? What was seen, what was heard, what were the themes that came out? This paper has some tremendous graphs, which I will not relay all the good information, or should I say tables, of what they found, what they heard, that can help each of us in our respective work as well. I think there's some key things though, before I hop right down to the results bullets that you can see. Really understanding the barriers and facilitators. And we'll talk a little bit more about that in a moment. But also, one of the key pieces that this paper acknowledges is comparison of units, right? We're not like that unit. We might be in ICU, we might be step down, we might be medicine only, we might be more surgery, right? And so as leaders, being able to step back and appreciate the moment and not comparing always across. So one of the key things is that they really found that staff with engaged leaders were really able to express what the challenges were on the unit, discuss what the operational or clinical needs were, right? And I think that's really important. When we think of shortages in regards to supply chain, this is one example sometimes that happens, right? The supplies have changed. How do you educate all the staff in a unit about that? But the other piece that was picked up on when they went through this content analysis was really reflecting and evaluating, and such an important piece of leadership rounds, not just jumping to solutions as the leader, because your experts that we recognize are on the front lines because they're the ones delivering the care. And then finally, the staff problem solving, which is a great thing as a leader to understand how are staff thinking about solving the problems that impact them in the work they do each and every day. 353 events when staff disclosed issues and problems related to hospital-acquired infections. And keep in mind, these number of events, right, for problem solving and staff disclosing were only done at 22 observations, right? So really that engagement and dialogue. The other interesting piece in this paper is that if you look at the graph, what they saw was a significant and rapid decrease related to CAUTIs, which again are those catheter-acquired urinary tract infections. And you see it before, right? We start to see it in their work before they started the leadership rounds. But then, because of the rounds, it sharply changes, right? And so one of the things this institution did was also added CLABSI, which are central line associated bloodstream infections, and C. difficile to these rounds. And one of the great things they did was sharing of data, right? Transparent data to the front line doing the good work. The next slide talks about a very different type of leadership rounds, right? Positive leadership walk rounds, which you heard a little bit from Brian about. What does it mean to safety culture and workforce well-being? The aim of this study was really to determine whether exposure to positive work rounds is associated with better healthcare worker well-being and culture of safety. I think this is really a critical piece. When we think about before the pandemic, which nobody ever wants to think about, to where we are today, we're still trying to stabilize, right? Depending on where we are, where we work, what we do, resource availability, and resource not just being supplies, but also the workforce to do the specific work that we need. So a lot of recalibration. This was a cross-sectional survey, over 13,000 healthcare workers, again, in an academic health center. Leader training was done. What was part of a 2-day leadership workshop was coaching and training around positive interactions with work rounds. And I think this is really an important piece. And the leadership engagement is critical to this, right? And when we think about people and personalities doing the work, we know there can be variability. So 4 key questions, right? From your perspective, you would ask, could you share 3 things that are going well in this work setting? What could be one thing that could be better? Another question, is there anyone you would like to give a shout out to today? Can you elaborate on those examples, right? And that's important, right? Raising up others on the team who do the good work, who are thinking about safety, quality improvement, potentially well-being of the team. Celebrations or successes that people want to share. And who do you think deserves special recognition for going above and beyond? With specific examples that as a leader, you can extract, take away, and email that person to thank them for the contributions. People who responded to the survey, the healthcare workers, they had to be a minimum of 50%, right, of a full-time equivalent, so part-time. And then what's really interesting when we start to get into some of the key pieces of the survey to evaluate this very specific item, one of the questions specific to this was, do senior leaders ask for information about what is going well in this work setting? And so when we move into the results, what's great, over an 80% response rate with the survey, which is really helpful when you start to look at this. And one of the great parts was 63% of those responding said yes, they'd been exposed to positive walk rounds, right? And so really contributing to that leader training, taking the questions and moving it forward one piece at a time. Data was further broken down into 4 quartiles. And one of the key pieces in it, you can clearly see improvement readiness was better for those exposed to positive walk rounds, local leadership, teamwork climate, right? We know, at least in healthcare, it is a team sport. And I am grateful for the colleagues I've gotten to work with in my career. Safety climate was better. Emotional exhaustion was lower in that first quartile, as well as burnout. And that's really important when we think about a culture of safety and advancing the cause. All right, well, transitioning to the next slide, what we'll talk here a little bit about is framing up the why. And this is specific to each of us, right? And to each of you, right? So some of the things to ask yourself is, how are you contributing and creating that culture of high reliability, right? Really focusing on that sensitivity to operations, right? The reluctance to simplify, Do you have a preoccupation with failure? A great question to ask the frontline staff is, what is one thing that worries you that could specifically harm a patient in your work environment, right? That preoccupation, deference to expertise, right? As a leader, I don't do what the frontline does. Yet I have to go and explore and understand. And then what does resilience look like in our organizations when we think about high reliability and an event does happen, right? Healthcare or non-healthcare market. How well can an organization and teams bounce back from those events is really critical. When we think about this, ask yourself, where is my organization? Where is my division or department? Where is my team? How do we think about patient safety, quality, and our goals? Is there a daily management system, right, that looks at escalation of issues, that brings voice to the front line, that comes up to leadership, right? Another way to promote how and why we need to think about leader rounds if you don't have that today. When we think about psychological safety and the role of interprofessional teams, this is critical to quality and safety. And the work we do as leaders to bring teams together so everybody understands everybody's role. It's easier sometimes to just think, I can do it by myself. Yet when we look at the beginning and the end, there's sometimes a middle, right? That middle of where work might happen, right? And so how do we all contribute to that when we think about psychological safety in creating that within our own teams and within our own environment? Communication is really critical though. Communication is the number one failure in healthcare, right? That leads to errors. And you can't ever say that enough because how we engage as leaders in communication and being willing to hear the message is critical. Another key piece is how well do you provide feedback, right? How does your institution provide feedback on issues you hear, right? Different types of surveys, a variety of different things. But really framing up the why for you. What's your escalation, your triage, your problem solving, right? How much do you engage in PDCA, Plan, Do, Check, Act, in multiple iterations? Yet at the end of it, hopefully, you can frame up the why for yourself as a commitment to safety to fuel the change we need in the future. The next slide highlights some key pieces when we start to think about the intent of leadership rounds, right? Being purposeful, right? That you're not going to respond to pages, text back, lose your distraction, your eye contact, the meeting, the ground rules that might need to be set. Think about, do people consider you trustworthy, right? Think about where the clinical knowledge is, right? We bring our whole selves to those rounds and the ability to be reflective on what you hear. The relational aspect of being able to say, tell me more, show me, why. I recently had a director say to me, I knew, Tracy, you were going to ask me why. And I chuckled and said, well, then you should have a really good answer for when I ask you why, right? Help me understand is one of my favorites. And it goes a long way because I have to show a little fallibility, my own shortcomings. I may not be the expert, right? I have to go to the experts. And all about the language we use, right? How we communicate in a positive intent or a negative intent. And what do we bring, right, to that engagement opportunity? How are we using our data, right? As we think about that level of understanding with the team, how do they see their data? Do they have access to the data? Is it transparent? And I think one of the key pieces, leadership rounds are more about listening more than talking. Sometimes we all want to just jump in and fix it. Yet I may not have the best solutions, right? I'm not doing that work day in, day out to take care of patients. So really listening to understand that problem deeply and taking it with me when I move to the next topic or round somewhere else. The other piece, though, I think that's really important is how can we role model and mentor this for others, right? Other leaders who might be part of our rounds, other times with the frontline staff as well. I think those are really key elements as we think about this important work. And it's all to say, when we think about interprofessional learning and education, the creation of psychological safety, creating that environment where staff disclosure and problem solving are really an engaging factor for us as leaders, as we saw with the hospital-acquired infection study. To me, I think it sums up really well. It's about the people who care for the people. It's not about me, and it's not about my ego. On the next slide, as you think about your work environment, how do you make space for what matters? It's a great quote by Martin Luther King. It's on a building in Atlanta, Georgia, for any of you who are there, right? We can't all fly, right? We can't fly at the beginning if we haven't learned how to crawl, if we haven't learned how to walk, if we don't know how to run. Yet it's about starting somewhere and making a commitment. What's the environment where you are today? What is the work you're doing in this space around leader rounds, quality safety, high reliability, psychological safety? Engage others from the C-suite, right? And if that may not work in your organization, maybe it's your quality safety team. Maybe it's employee health, depending on what it is you're trying to solve, right? Thinking about the commitment, right? Because it is a commitment. It's a commitment of time and resource, right? On your part and on those you're engaging with. Understanding your own comfort zone and recognizing that, wow, I may not like what I hear when I go there, and yet you have to be okay with that, right? Think about the areas and units. Is it focused? Is it going to be something very specific to hospital-acquired infections or very broad? Think about the surveys you use today, your ways of knowing in your organization today. That could help inform this. And I'm a big fan of partnership, right? All it has to do is start with one and the one follower, and then you can get traction and move forward. The next slide speaks a little bit about some questions you may want to ask. Now, many of you have probably seen these boots before, but I wonder if you know where these boots are, and they are not at the LL Bean store, but you might know where those boots are. So these are just some questions you might want to ask, right? Do you have the supplies you need, right? Very simple question if you've never done this before, right? One of the things, if you're working on workplace violence, able to round on your areas, inpatient, outpatient, right? Any type of setting. When we think about workplace violence, are people being kind today, right? What is the work your organization is focused on? Same with hospital-acquired infections. Is it something related to patient experience? And we're looking at call bells or response time from a portal message, right? Shaping some of those questions that you might want to ask. I also think it's important to ask staff specifically, do patients and families share concerns with you? And what are we hearing about that? Another critical piece of information. And again, what obstacles are in your way from preventing central line infections? If you are very focused on a very specific topic, that is a really great question. You can also do these from the lens of human resources. When we think about engagement, right? Many ways to think about the questions you might want to ask. The next slide. So now you've gone, you've heard, you've seen. What do you do with what you hear and what you learn? I really think Albert Einstein shares this well. If he had an hour to solve a problem, he would say 55 minutes to think about it, 5 minutes thinking about the solution, right? What are we trying to solve? And so a variety of ways to document, from paper to computers, looking at trends, comparative reviews, and they inform future work on what are we trying to fix. And my next slide just wraps it all up for us. What are your next steps? Find other like-minded individuals. I can guarantee you, you're not alone. Keep it simple to start. 1 or 2 questions. If you're extremely introverted, go with someone else, right? Think through your approach and determine your path forward. Most of all, you have to start somewhere. My final slide just highlights some resources for you to take away. And I want to thank everyone for having me here. And Brian, I'll turn it back to you.
Thank you, Tracy. Oh my goodness, we already have some questions coming in. We will get to those in the Q&A in short order. I've got some questions as well. But for our next speaker that we want to bring forward here, Dr. Tom Gallagher. Dr. Gallagher is a professor in the departments of medicine and bioethics and humanities at the University of Washington, where he's also associate chair for patient care, quality, safety, and value. His research, including over 120 articles in top-tier journals, by the way, his research addresses the interfaces between healthcare quality, communication, and transparency. He is executive director of the Collaborative for Accountability and Improvement, and he was awarded the prestigious Eisenberg Patient Safety and Quality Award by the National Quality Forum and the Joint Commission. We would love to welcome to the session today Dr. Tom Gallagher.
Thanks so much, Brian. Concepts like psychological safety and how it informs an overall culture of safety can sometimes feel a little bit abstract. How do you know how psychologically safe the workforce at your organization is feeling? Well, I would recommend that you watch what happens when something goes wrong. As Brian said, if culture is how we do things around here, what happens in those cases? Do leaders blink? Do clinicians put their head down, look the other way, and hope that everything blows over? These responses are understandable. They reflect normal human reflexes that we all have, but unfortunately, it takes a bad situation and just makes it much, much worse. Fortunately, there's now a robust set of tools and resources to help. But to put this in even a more practical context, on the next slide, I wanted to start with a case. And I want each of you to think about how would you respond? So you're a hospitalist and you admit a 60-year-old unhoused patient with hemoptysis, coughing up blood. Admission CT scan shows multiple lung masses consistent with metastatic lung cancer. You remember this patient from an admission 1 year ago for pancreatitis. An abdominal CT scan shortly before the patient left the hospital against medical advice commented on an incidental, suspicious mass in the left lung base. You mentioned this finding in your discharge summary, but reviewing the record, it does not appear anyone followed up on it. So, how does psychological safety contribute to what this hospitalist does next? As Brian said, will they use their voice? How likely are they to submit an incident report about what happened? How likely are they to discuss the prior CT scan results with the patient? How likely are they to reach out to the patient's primary care physician? Well, I think the way we respond when something has gone wrong on the next slide is really the ultimate stress test for psychological safety. And much of this work hinges on understanding and embracing transparency. My colleague Julie Morath is fond of saying transparency is a precondition for patient safety. It's not something that's nice, it's not something that contributes, a precondition to patient safety. And when clinicians are involved in harm events, they face multiple challenging decisions. It's one thing to answer a question in the abstract on a survey or during leader rounds about whether you would speak up and what you would say and how you would respond. But when the moment of truth comes, what are we going to say to a colleague? Are we going to report this to the organization? What are we going to say to the patient? I think what's so interesting here is that there's a bi-directional relationship between how we respond to harm and psychological safety, because the presence or absence of psychological safety within a culture of safety plays a powerful role in how clinicians respond to harm events. But in addition, by learning how to respond effectively to harm events, taking advantage of some of the tools and resources and structures, the way we learn to respond on a daily basis when something has not gone well, and doing so with accountability, transparency, and compassion actually reinforces that psychological safety, because people watch, how do we do things around here? I was watching my colleagues. They responded with openness, with accountability, with learning. That makes it easier for me in the next case of a harm event to respond with transparency and builds psychological safety. On the next slide, we talk a little bit about why this is so hard. We all aspire to openness, to compassion, to accountability, to making sure we learn when something has gone wrong. This has been the primary focus of my professional career. And when I first started working in this area, I thought I might be making a mistake. I thought people might get the hang of responding to harm events with transparency very quickly, and I would need to move on to another topic. And that has not been the case. And that's because we're hardwired within our human nature to struggle in these sorts of situations. Think about when you were involved in a harm event, either personally or professionally. It's natural to want to keep problems to ourselves. It's natural to want to avoid difficult discussions. We've worked with several hundred organizations on implementing programs around communication and responding to harm. And I would say at each and every one of those, if we were to get a frontline clinician, if we were to do the leadership rounding that Tracy just described to us, and ask them, what do you hear from your organization about the way we want to respond to harm events? You would hear some profoundly mixed messages. Mixed messages like, of course we want you to be open, but don't say that. Or it's okay to apologize, just don't admit fault. We're afraid, we're ashamed, we're embarrassed, we don't know what to do or say. And many of the elements of a response to a harm event, while they exist, are not hardwired and integrated to work together. On the next slide, we highlight the development of what are known as communication and resolution programs. Communication and resolution programs are patient safety programs. CRP is a generic term, and there are multiple different specific examples of communication and resolution programs. And CANDOR is a wonderful example developed by AHRQ. And it's not an understatement to say that the field of communication and resolution programs really would not exist today if it were not for 2 decades of support in this space from AHRQ. Communication and resolution programs are principled, they're comprehensive, they're systematic, they're compassionate programs that involve early incident reporting, open and honest communication, care and compassion for all, reconciliation, learning, and improvement. And it's a really exciting time in the field of communication and resolution programs. And please stay tuned. The evidence base supporting CRPs keeps growing. And shortly, there should be a very nice and comprehensive evidence synthesis that brings together all the different streams of research and evidence that support the utilization of communication and resolution programs. CRPs are so well recognized as a patient safety intervention that on the next slide, they're actually a part of the National Action Alliance to Advance Patient Safety. Safer Together Recommendation 9, Tactic 9B, implement and maintain programs for providing appropriate ongoing support in the aftermath of harm, and Tactic 9C, institute communication and resolution programs for patients, families, and caregivers. And this is just one example of the multiple national recommendations, including things like the CMS Patient Safety Structural Measure, that endorse and support the use of communication and resolution programs. And that evidence base on the next slide is helping to inform a variety of self-assessment tools. This is also from the Safer Together toolkit. And you can see on communication and resolution programs, it asks organizations to score. Are they at the beginning? Are they making some progress? Are they having a significant impact? And are they at an exemplary state? And you can look at your leisure about what are all the different pieces that go into making an assessment of this type. On the next slide, the CANDOR toolkit was really a game changer in terms of helping organizations who wanted to move in this direction know what to do. And the learning collaborative that we lead together with Ariadne Labs and IHI called PACT has built on the CANDOR toolkit and has a whole host of other tools and resources that you can use to advance a communication and resolution program. A heavy emphasis on measurement. How do you know how your communication and resolution program is doing? How do you do the communication with patients, with families, with colleagues? What are some of the process tools? And some of these we've developed, some have come from other places like the Betsy Lehman Center. And then this should be the most patient and family-centered part of what we do in healthcare, responding to harm events. I would argue that at the moment it's the least. It's not because we ignore patients and families in the aftermath of harm on purpose. It's just that we're so focused on our own needs as clinicians, on our needs as organizations, that the patient and family's needs inadvertently recede a little bit to the background. These tools and resources on the next slide are free and publicly available. We want you to download them and use them. Here's an example of a communication tip sheet for the initial conversation with patients and families about harm events. And there's also a very robust, on the next slide, tip sheet that Julie Morath and colleagues helped put together on how do you create a psychologically safe environment for which, in which communication and resolution programs can succeed. And I thought I would just end with this next slide here, which is from that tip sheet, and it draws on Amy Edmondson's work that really focuses on, in the left-hand column, leadership tasks, what those tasks accomplish, and what the stance of the leader should be when accomplishing those tasks, setting the stage, inviting participation, responding productively. And in the bottom right there, you can see orientation towards continuous learning. Communication and resolutions are about ensuring that when something goes wrong, we respond with accountability, compassion, transparency, and learning. So what are some practical steps that you can take on the next slide? If you're a clinical leader, I would really encourage you to start doing a gap analysis on your current CRP. I would say the most common thing we hear at organizations when we talk about CRP is, oh, we already do that. And when you look just a little bit under the hood, you realize this isn't what they do at all. They use their communication and resolution program occasionally, but not each and every time. As a leader, how do you make sure that your CRP is hardwired? What metrics are you using? How are you communicating to your staff about the importance of CRP? If you're a risk, quality, or patient safety relations expert, try to understand, well, what is my role within the CRP process and how can I be an effective harm communication coach? And for frontline healthcare workers, you need to know, what is a CRP? Why is it important? What is my role? And how to access local support. It's such an exciting time in the field of communication and resolution programs. These are the ultimate stress test of what is the current state of psychological safety within a current culture of safety at this organization. And I'd be pleased to pass things back to Brian and hear your questions.
Thank you so much, Tom and Tracy, for your topics today. There are questions that are kind of pouring in the chat, and we will get to as many of those as possible. A couple of themes that emerged in dealing with kind of what we're considering to be kind of culture change strategies through psychologically safe kind of tactics like this. What are some of the obstacles, and this really is to both, what are some of the obstacles that you've run into when you're doing, whether it's candor, culture, or leader rounding in a way that makes people feel seen and heard? Could you describe some of the obstacles that you experience, and then how you respond to those obstacles? Because people are kind of ready to roll up their sleeves and get some dirt under their fingernails, it sounds like, and they want to know what they're going to run into when they try doing this. Maybe we'll start with Tracy.
All right. Well, I think part of it is it's establishing that baseline culture of trust, right? Trust, humility, being willing to hear. Because if you're not willing to hear, they're not going to be willing to tell. I think that's really, for me, it's being able just to listen, right? And to establish a relationship. I think one of the other pieces is with the obstacles is we don't know the answers, right? We might think we do, but I think it's that vulnerability in the setting when different items might arise of being able to change the question, right? To ask the team what they think for their input, right?
Here's
And
what I hear you asking, but let me put it in other words. Is this correct? That's what therapists do to kind of make a patient feel like they're really being seen, as they just kind of reflect back the same question in different words. But that really shows that you're listening, or
yes,
and interested. And boy, I can vouch for that, Tracy. I have walked into work settings that you have recently walked out of, and people are all just like, "Oh, we just got a visit from Tracy," and you do make people feel seen and heard, even in this seemingly kind of professional activity that you're doing. It has a very interpersonally kind of rejuvenating effect, I think, especially when you're doing it with that little je ne sais quoi, that making them feel seen and heard. So very, very cool. I don't know, Tom, if you wanted to add anything from different tactic but same kind of principle.
Well, I would encourage people to focus on three things. One, the area of CRPs or candor is it's rife with misconceptions and education and knowledge gaps. So the more that all leaders can talk about why communication and candor style programs are important, what they involve, why they are good not only for patients and families but also clinicians. It helps address some of those misconceptions. I agree 100% with Tracy that trust is paramount, and especially when something has gone wrong, or a high harm event in particular. This is upsetting for senior leaders to realize that their clinical workforce may not trust them because they feel like, I'm a high integrity person. This is a high integrity organization. Of course, we're going to respond appropriately. But clinicians generally, and all I can do is speak for physicians, they really worry that when something goes wrong, is the organization going to have my back? Or at the end of the day, are they going to do something that benefits the organization but puts me sort of in the crosshairs? And they get to that point through lived experience. And so, really trying to gradually build trust with clinicians is critical. And then, lastly, it's really about partnerships. The response to harm is a clinical activity that has legal implications. It's not a legal activity that happens to take place in the clinical space, but all of the stakeholders, whether it's quality, safety, patient relations, risk, claims, legals, They all play an important role, but they have different perceptions of how we ought to handle these cases. And if you don't have a shared mental model and strong partnerships, when you get into the middle of one of these situations, those differences of opinion can really rear their head. So, closing the knowledge gaps, building trust, advancing partnerships.
I love that. That's and I think one of the things that you touched on is the broad applicability of some of these concepts. And here's a question really for both of you. It's tricky because in my notes I wrote down TG for both of you, and your initials are both TG, so I have to go back and look at my notes. But basically, what applications do y'all see for these concepts outside of Tracy, of in your example of leader rounding, like staff meetings, when you're on a Zoom or maybe in a hybrid format? Can you use these same principles? Do you see them as kind of transferable outside of the context that you were particularly focused on?
I think they are, right? Whether it's a format like this, whether it is a town hall forum, depending upon the type of setting, right? I think as you grow up in leadership from different roles, you have to be comfortable being uncomfortable. And that is really hard for people because I think Tom said it well, like, you know, from the clinician viewpoint, it's like, what are you trying to do to me? But as a leader who is a clinician, right, you sit in both camps, and it's really getting good at being uncomfortable and hearing the messages when you need to hear them. So I think the applicability across different settings and modes and types of business are pretty broad.
I think something that I've heard too, Tracy, is that people know when they see you coming that it's going to be a meaningful interaction, so they don't run away. There are other leaders that when they approach a unit, it's like, oh gosh, look who's coming! I'm out of here. I'm going to be in pod C. I'm busy, or whatever. And I think that it's the consistency with which they know that you're showing up and kind of presenting in a way that's genuinely meant to kind of to be helpful and to bring clarity where there is clarity to be had. Which leads us to another a series of comments that came up in the chat about apologies. And so I'm really curious too, if we can start with you, Tom. When you're trying to be transparent and you're trying to be as kind of forthright as possible, can you talk a little bit about your experience in leaders apologizing to frontline staff and how that comes across, how you manage that? It seems like there are legal landmines that you're trying to avoid while trying to kind of apply a soothing balm to people who are kind of raw in the moment. And I don't know if you have any reflections on just the act of putting forth an apology in those interactions.
Well, you asked about sort of broad applicability, and I think the skills that are involved in responding to harm with transparency, compassion, accountability, empathy apply across a whole range of difficult interactions. And some of those interactions might be a frontline worker bringing up frustration with a problem on leader rounds, and Tracy's having to deal with the fact that the clinician said, I reported it, no one's done anything. We talked with you about it last time, it's still a problem. And, it's all about sort of the trust building, the information sharing, the empathic communication. Apologies are important. They're just one element of demonstrating caring and building trust in situations where you're having difficult interpersonal interactions. And if you look back at the communication tip sheet, that's what's up at the top in terms of goals. Demonstrate caring, build trust. I would say clinicians are getting a little bit better at the information sharing aspect of this, but especially where physicians can learn an enormous amount from our nursing colleagues is in the emotion handling. I don't quite know why physicians struggle with empathic communication, but nurses, by and large, are masters at emotion handling and empathy. And I'm sure that if you saw Tracy in action and she was dealing with a frustrated frontline clinician of any stripe, there'd be lots of apology, there'd be lots of emotion handling, and it would build the trust to help that interaction go much more smoothly.
Yeah, I love this example where when we would do hundreds upon hundreds of debrief, because we have, in our organization, we have over 400 work settings, and we would do hundreds of debriefings of culture data. And what was so interesting is in those debriefings, frustrations would emerge inevitably about how something is not what they would like it to be. And just the act of in that moment, just pausing and saying, "Wow, I'm really sorry that you're having to deal with that." Even though I wasn't there in a formal leadership capacity, I was just there to debrief their data. I think the act of hearing someone apologize in a genuine way, it has a therapeutic effect, and we need those little boosts wherever we can get them. And leaders have enormous power to confer that therapeutic effect in the way that they're interacting with staff. I really like that. We only have a couple more minutes here, but Tracy, you mentioned this, and Tom, you hinted at it as well. The idea of variability in the leaders that are doing this work. Like some people are naturals, and some people are less so, meant to be put in front of angry crowds. What do you see, just in your experience? Can you speak a little bit to people who are better suited to do these kinds of interactions, and people who are perhaps not as well suited?
So
And I'm talking about leaders.
yeah. So I think there's a couple things, right? I think everybody can learn. So I think there's sometimes this, oh, Tracy, you must be really extroverted. Nope, nope, not at all. Not at all. And it takes my own courage till I kind of get to know lay of the land, the people, the issues, right? And understanding the environment. So I think there's that. People can learn, coach, bring people along, mentor. Start with easy questions, right? Don't start with, so how do you boom? You might not be prepared, right? So build it up over time. Select a core set of units. Don't think you're going to go to 400 units, right? Select a
Mhm.
core set, right? Gain your ground. Where might you have some knowledge? I also think it's important that from a leadership standpoint, you acknowledge and recognize this is part of your job, right? And for me, it's the best part of my job when I'm not in a meeting and I can round. I don't go tell anybody that, right? But it's to understand what is the work we should be doing to support those on the front lines who are trying to provide care, right? And so those are my thoughts on that. I'll see what Tom thinks.
I do think people can learn and improve. We do all sorts of training and simulation work, and there are multiple ways to achieve the same goal. I think if you watched 10 people on this webinar handle a difficult conversation, they would be achieving the same goals, but doing it in different ways. You won't learn if you don't practice and get feedback. That said, there are some people who are especially skilled at this, but I think everyone can learn the basics of doing this well.
I I I agree wholeheartedly. Some are faster learners than others, but this is something. It's a muscle that we can make stronger with repeated use. Thank you both so much. I would love to go to the end, and just to remind folks, yes, the recording is available on the website. Yes, you can share the recording. Please share the recording. It's meant to be a resource for folks. And Tom, your tip sheet links have been put into the chat as well. People were requesting that, so that's been provided as well. Just at the end of our time here together today, I wanted to remind you about an upcoming event. We will be doing the second in our series next month on March 18th. It will be the second in our series of 3 on safety culture, and it's how to improve teamwork norms and how to improve patient safety norms very explicitly. Those are two of the two domains that are constantly kind of in the deficit area when we do culture of safety survey assessments. So we'll be talking about AHRQ resources that can be used to address that as well. We'll see you next month. Same bat time, same bat channel. Until then, thank you, everybody, and have a great rest of your week.